Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Hey, George, it's Tuesday and we're recording another phenomenal show with a phenomenal guest who we had the pleasure to have some time together in Orlando this year.
Yes, today we have Dr. John Sutter. The topic for discussion is an interesting one, the Pediatrician's Bill of Rights. This has been going around for decades, right? Now we're going to get some traction going, I hope.
Dr. Sutter has been a pediatrician for 40 years. He has worked extensively within private practices, group practices, hospital administration, insurance companies, and physician organizations. He's also the main author of the Pediatrician's Bill of Rights document, which we will discuss. Welcome, Dr. Sutter. It's a pleasure to have you with us today. We always ask our guests, why did you become a pediatrician?
Multiple factors. One of which is my kids were born when I was finishing medical school, and I felt helpless when they were sick. That was one thing. Secondly, I liked the idea of dealing with a comprehensive approach to medicine rather than dealing with just one organ system. The more complex the issues, the more it appealed to me. So,
Wow. And you, along with some real luminary leaders in pediatrics, Dr. Kane, Dr. Birch, Dr. Sawelski, I think I'm missing somebody out of that great list, have published what you have called the Pediatric Bill of Rights. What are the primary goals of this paper or manifesto that you've published online?
like many things, it was trying to consolidate and condense all of the major issues being faced by pediatricians with a summary paper that could be addressed point by point realistically for both legislative change and possibly even judicial changes to help everyone.
Did you model this after some paper at the American Academy of Pediatrics?
No, I modeled it after a paper I did when I was in graduate school 25 or 30 years ago when I was going for a master's in health policy. I had a course in health law and we had to write something similar. And it always stuck in my head. And then when people started making all these complaints over the last maybe 6 months of time, I tried to pick out the most salient features and address them point by point.
But all these complaints, they seem to be the complaints that I've known forever that never seem to have been ever resolved by anybody. No organization helped, no nothing. Am I wrong?
Actually, you're wrong. Some of those points were addressed in various litigation issues and temporarily got resolved. Going back to around 2002, there was the HMO settlement case that involved a half a dozen managed care plans. It was heard in federal court in Florida. There were a whole bunch of stipulations to that. The statute of limitations ran out and the insurance companies went back to doing the same things they had been doing all along. In my cases, also filed around the same time, there were certain stipulations, again, that were required that had since expired and make it very difficult to address unless we are able to create a grassroots movement and get organizations such as the AMA and the Academy of Pediatrics to use their weight to try and push for legislative changes.
So I have to push back a little bit. Do you really think the AAP has any weight?
Yes, if they wanted to.
Oh, if they wanted to.
They
If you can move a boulder, if you have a fulcrum and you focus all your effort in moving the boulder, or you can pick water out of the ocean and put it in a bucket and the world never changes. And I have not seen physicians, pediatricians organize, and family practitioners, because they're in the same boat as we are, to use a fulcrum to move the boulder.
The Academy of Family Practice is a whole separate agenda and has been much more aggressive in their actions.
Absolutely.
The Academy of Pediatrics has been more intimidated by fear of legal issues, and they represent far more in the way of specialists and hospitals than primary care pediatricians. It's a separate world. And the family practice organizations are far more independently organized and much more aggressive. They do far more in the way of advertising. Simple advertising, a one-page ad in the New York Times would accomplish more than all of their thousands of emails about what they are doing.
I agree. And then the AMA is not the AMA of old. The AMA is a corporation that makes tons of money from the CPT code book. And they don't want to rock the boat in any way that the feds will take away that monopoly that prints money for them every day. Am I wrong on that assertion?
Not at all. The AMA has a very strong legislative presence. They have a lot of clout, but it's being addressed in the wrong issues. The AMA traditionally has been very top-heavy in specialists, and in particular, in the surgical specialties. And they are, like many organizations, more interested in representing those groups than representing the primary care marketplace.
Probably all because of the RVUs are much higher for surgical specialties than they are for the good old pediatrician.
No, but the reality is they created the RVU system,
Right.
and they own the CPT code, and a bunch of surgical specialists sit around a room on a table and they decide what value to give to each procedure.
Right.
And because the AMA is full of specialists, and here's where I do agree we can't compete. I can't compete with a surgeon making $2 million a year in the amount of money I give to any cause. And so the big pocketed surgeons make sure that the AMA gets fed and that their interests are represented. Everybody else eats what's ever left. That's the problem. What specific changes are you calling for in this document?
More of just a wake-up call to people to start thinking about how they can approach change. How, if you go to a congressman or a senator and say, I want this, I want that, you're not going to get anywhere. But if you can pinpoint a couple of key issues, you have much more leverage. The problem is no one is going to do it.
So what these are challenges that we face in pediatric care. What are some examples of these challenges?
In particular, now you've got CMS has set a certain amount of money aside. Think of it as a big pie, and they divide it up into different groups. That pie doesn't change. How they divide the pie changes every year, and our portion of it shrinks each and every year. They are looking at trying to freeze expenses, but not looking at the bigger picture of long-term problems. If you address the issue of, simplest issue is pediatric and adolescent obesity. If you address that with proper funding, you would address so much more of the expenditures that the government is going to be faced 30, 40 years from now. But they don't look that way.
I'm going to circle back for a minute, just to level set. There is a primary care collaborative that does publish some very good advocacy papers. And they estimate that out of the $4.5 trillion that's spent in healthcare today in the United States, the primary care doctors get 4.5%. Yet the primary care doctors do 50% of all patient visits in the country. And in addition to that, the biggest spenders are the hospitals and the insurance companies that take about 50% of the pie. And so that's part of the problem. You're absolutely right. If we had as a goal healthy, happy children that are literate and good citizens, and that was our collective goal, we would be doing much better, but we're not. And that costs us a lot of money on the back end on diseases that can be prevented or modified before they cause hundreds of thousands of dollars in the hospital. But we don't talk about that. I think when you talk about this, I have a question for you, because if I'm a congressman, I'm going to say, you're a rich doctor. Don't you have a private jet and a couple of apartments in Miami and Santorini? All doctors, don't they?
This is the same issue that I faced 25 years ago when I tried to sue all the insurance companies. Everyone was afraid of rocking the boat. Everyone was afraid of backlash from the insurance companies. Everyone was afraid that their incomes would suddenly become public knowledge. If in fact their incomes became public knowledge in primary care these days, people would be shocked when architects, engineers who have far less expenses in education are earning double what pediatricians and family practice and primary care doctors are earning. Something is seriously wrong. And there's no reason to be afraid of that information becoming public.
No, I agree with you. And I think most families, whether they're on a failed program called Medicaid or whether they are on commercial insurance, don't have a clue that we're getting paid $50, $60 to do the physical for their child. They would be shocked. They would be shocked.
That's why it's important that we do some form of advertising and public information campaigns, which has always been shied away from. It has been one of the things that I have addressed numerous times to the Academy, is that they start putting stuff like this into newspapers like the Washington Post or the New York Times, a one-page ad, and showing that is your 5 cents out of every dollar you're spending on healthcare going to your pediatrician correct? Or should they be getting more?
And because these families are paying $37,000 a year for a family policy, I'm not getting 5% of those $37,000. I'm not getting like 0.0001%.
As you look at the administrative cost of insurance as well, they are badly organized, they're badly run, yet they still are spinning off anywhere from 15 to 22% profits for their shareholders. On top of that, you add on another 15 to 20% in administrative costs. It's absolutely absurd. If they eliminated all the pre-authorizations and stuck to what they were intended to be as an insurance product, they would reduce their cost, and there would be far more money available to primary care.
So what I'm asking you is why? Why should I care?
Why should you care as a pediatrician, or why should you care as a parent?
Why should I care as a citizen? Doctors make enough money. $200,000 a year is a great salary for most Americans.
But it's short-sighted. The amount of work to maintain that kind of income is destroying private practice. And not only private practice, but even the hospital-based practices and private equity-based practices. They can't survive in the long term doing that. Their income is eroding steadily year by year. The cost to get to that point where you're even able to earn that has created such expenses. If you think about it, you're basically not in the workforce till the time you're 30. You've lost out on 10 years of life earnings to become a doctor. Think about it, even if you were earning half of that in those 10 years, what that would have amounted to. It's ridiculous.
So let me flip it around on you. I'm going to tell you my why. Okay. So yesterday, I got a text message from a friend of mine in Miami. She's a wonderful human being. She has 2 children, one's 7 and one's 1. And I've been the remote pediatrician since Mason was born. Unfortunately, Mason collapsed and he was rushed to the emergency room in DKA. So now Mason's got type 1 diabetes. Of course, the mom's crying on the phone. She was not happy with the pediatrician she saw the night before Mason collapsed, who just said it's a cold, go home, despite the fact that he'd been losing weight. She was not happy with the endocrinologist at the hospital. I wrote an email to a friend of mine in Miami, another Colombian physician, and they're going to take care of Mason tomorrow. Mothers in America should not need a podcaster to get their kids to the right care. When she called to confirm the appointment, my friend in Miami is booked for the next year. When I have a child who fails an MCHAT in Virginia, and I want a behavioral pediatrician to see him, it takes 2 years to get an appointment. In those 2 years, that child doesn't receive any care. Every month that they don't receive care means an additional $200 to $300 in expenses to the health system. When I have a child that needs a speech therapist, no, not a speech therapist, a talk therapist that does CBT, in Northern Virginia, if you don't have $180 to $300 in your pocket to spend every week, you won't find one. When I have a child that I don't know what their mental illness is, but they're not normal, you can't find a pediatric psychiatrist. Pediatric endocrinologists, pediatric infectious disease, pediatric orthopedic surgeons, pediatric, you name it. They're so underpaid, and they spend 15 years to be able to help me when I have a patient I can't deal with, that we are denying care to our children right and left every day. And this is not what a kind Judeo-Christian society does for its young.
Right.
The lack of payment is affecting access to every child and every pregnant mom in the U.S., and we cannot stand for this anymore. We need to wake up and make this a priority.
I bet you if they paid with a credit card or a check or cash, they would get a psychiatrist tomorrow.
If they have the money.
That's the problem. That's the catch-22. I got a message from a new grad fellowship trained pediatric psychiatrist that's looking to rent space for his all cash solo practice. All cash, no insurance.
You can't blame them.
Yeah, the problem with that is that they can't survive in some areas of the country.
Yeah.
They can do it in more affluent areas, but the areas that need the pediatricians most, they could never survive. There are numerous people that I can think of that have tried doing that in the New York area in the past, or in particular, a group of surgeons, and they lost so much money and so much revenue that they went back to signing contracts with managed care companies.
That's not true in psychiatry. In psychiatry, they do med checks at $150 a med check, and they're doing $500 an hour, and they're doing very well because there's no one else. And that was the exact same. That's a wonderful analogy because Kennedy moved mental illness out of a broken system, which was abusive, and they never funded the community-based psychiatric services. And then they went and did what they are doing now with nurse practitioners and physician assistants, which was work at the top of your license. A psychiatrist does not need to do talk therapy. They manage medications. And what happened? Now you can't find a social worker, a psychologist, or a psychiatrist that will see your kid when they're depressed for therapy because it was never funded. We never paid for it. So if you don't have cash, you're out of luck. And that's a system that is being built out in pediatrics. Only the top 10% who have cash will see pediatricians if we don't address the payment problem.
This episode is sponsored by our friends over at Freed AI Medical Scribes. Let's hear what they have to say. What if you could take the computer out of the physician-patient relationship? With Freed, you can. Freed is the AI medical scribe that listens, transcribes, and crafts perfect soap notes for you seamlessly. This isn't just another productivity tool. Freed is a life-altering solution for physicians, helping you regain the joy of practicing medicine. Freed frees you from the burden of documentation, so you can focus on what really matters, your patients. With Freed, the computer is no longer a barrier. It's a quiet assistant that works in the background, capturing every word of your patient interactions, accurately and quickly. The result, you're fully present in each visit, building stronger connections and offering more attentive care. And when the day is done, your notes are too, leaving you with more time to focus on yourself, your family, and your life outside of medicine. Freed is the solution thousands of physicians swear by to reclaim their passion for medicine. Try it free for 7 days, no credit card needed. Visit getfreed.ai and rediscover what you love about being a doctor.
So I guess that's where you mentioned the devaluation of pediatric care in your article, Dr. Sutter?
Exactly.
Yep.
And now with a bigger issue is the push for the CMS is basically trying to push value-based systems, which could save money if they are addressed properly. The problem is the metrics that are being used are incorrect. They don't address pediatric issues at all. They were never designed for pediatrics. If they were, there would be a big change.
There's always this talk about this value-based care, okay? I've gotten pretty good at understanding it. The metrics are not unreasonable. If you really look at the population, you'll find people don't get their flu shots. You'll find people don't come in for their checkups. You'll find that adolescents don't get their HPV vaccines. They don't complete their primary series of vaccines by 2 years of age, and so forth and so on. And Herb's favorite BMI metric and all that kind of stuff. The problem comes about value-based contracts are based, and the numbers are based upon a budget that's given towards the patient. So the value-based contracts happen off of the state. So the state budgets X amount of dollars for a pediatric case. Now, most pediatric cases have a very low risk score. Hence, very little money is budgeted towards that kid. And then every now and again, you're going to have a kid with a brain tumor that's just going to explode everything, because you'll have 100 kids with low risk and then one kid that has very high risk that goes to Memorial Sloan and gets thousands upon hundreds of thousands of dollars of therapy. It just blows the contract out of the water. I've seen it firsthand.
That's correct.
I have to ask,
It's been going on that way for a long time. But the problem is there are things called stop loss that could be instituted. The bigger issue is the attribution of the patients in a value-based system.
Right.
what does value-based really mean? What does value-based really mean?
The problem, value-based means that you are paying based on the quality of outcomes. It can be interpreted in a lot of different ways. It means that you're placing more value on patient long-term care and keeping them healthy than you are on dealing with piecemeal illnesses. And if you can keep a population healthy overall, you should be able to get paid better than someone who has them come in every time they sneeze.
Yeah, that's the word. Because I know for a fact, in general, pediatricians have good quality metrics.
That's not true.
Even the worst guy, Herb.
No, that's not true.
All right, Herb, hold your thought. Even most of the people have good quality metrics. The problem with these value-based contracts is they also add this PPAs and PPDs, preventable admissions and preventable visits and so forth. So if you reduce the amount of emergency room visits, and that's where it gets tricky with the risk and the medications and things that are out of your control. You don't make it there. The quality is always made, but you won't get any money because you didn't do the preventable admissions. You lost the quality. So, it's a shell game. They're just moving the things around.
First of all, it's not a payment. John King says it is retained earnings.
Yeah.
They hold back some of the money they should be paying you for
Yeah.
providing care. And if you're nice and you get on your knees and you beg, you
Right.
might get some of it at the end of the year. That's a
Right.
problem. Number two, value-based was an Obama-based euphemism that means we need to cut costs. And
Right.
that's where the preventable ER, the preventable, are you using generics, the number of consultations you're doing comes into a big factor. There are some things that I can control, and there are some things I can't control. If somebody calls that, I don't know, the other day I was in the office, a well-child exam, 4 weeks old, came in, the parents are not very bright. The kid's got 102.5 fever, and you need to go to the emergency room. What am I going to do? I don't do spinal taps. I don't have a CBC machine. I don't do blood cultures in the office. That's what the emergency room is for. I can't avoid those. And the last point to that is that there are certain behavior which you cannot hold a physician accountable for. I can talk to you about your BMI. I can tell you what a healthy diet is. I can encourage you to get the flu test, the flu shot, the flu vaccine. You as a parent have a right to tell me, doctor, I don't follow that advice. And my kid's going to keep eating and growing fat. And I have no control over that. And so and there's no accountability for the parents when they make the wrong choices. Where if there was a carrot and a stick on the consumer side, you better be sure that people are, because I see it like the big employers here will give, which is insulting, will give their employees a $250 cash card if they get their physical done with a primary care doctor. But as primary care doctors, we're getting paid $70 to do the exam.
There was some companies, some managed care Medicaid plans that would give gift cards if they would go get checkup and they get there were some people that would game the system. They'd leave with $300 worth of gift cards to Toys R Us.
Another approach to value-based care that seems to have disappeared in the early 2000 era. There were a bunch of different proposals that were on the table for episode of care payment systems, which is actually what I did a lot of my thesis on. But one of the things that was proposed is giving patients a set pool of money to take care of their healthcare needs for the given year, projected on what would be an average expense. The problem was that it never got off the ground. But if that were the case and you shift the decision-making, some of the decision-making about when to seek medical care to the patient, it would also change the metrics tremendously. The patient, if they knew that they would be covered for and have no risk at all for their well visits, but the risk was shifted to the patient to take care of what their needs were, it would change things. Instead of relying on the emergency room, they would get more, they would have less of an expense if they waited and saw their primary care doctor. All of these things would be molded into a value-based system that had to do with episode of care over the course of a year. It could also be done with asthma. Almost any kind of chronic illness could be set aside into a separate fund. You deal with people who are being forced, especially in the inner city areas, in order to survive with Medicaid rates as low as they are, to have people who basically work off of volume. The more you see, the better off you are. If you don't see 50, 60, 70 patients a day, you're going to starve. And the only way to do that is to sacrifice on quality. So it's a catch-22 that needs to be changed.
Right. So it's not only payment, is a physician can't see 30 and 40 patients a day.
Not anymore.
Good job. No, you may not kill anybody, but you're not going to do a good job. No. And that needs to be acknowledged, that Any system that is thought of for the future has to limit the patient encounters to no more than 16 in an 8-hour shift, so that you can walk and chew gum. You can do the well child, do the preventive, you can do the chronic disease management, the consults, and you can do the acute care, so they're not in the urgent care or the emergency room. But rarely does payment and the number of visits comes up in the discussions, because we've been put in the treadmill like little rats with cocaine. And we've been told the more volume you do, the more money you make. And you cannot make up, if you're losing 50 cents on every visit, you can do 100 visits a day. You're still losing 50 cents on every visit.
In fact, it's works the other way. If you start when you start dealing with high volumes, if you look at any kind of business model, when the volume exceeds a certain point, your overhead expenses increase at a proportion with the income that you're generating. So it actually works to your disadvantage when you get to a certain threshold.
Yeah.
Now, you seem to be concerned about the disadvantage of inner city kids in the system. Why is that?
Why? Because they're the ones that get the worst care, because they're subject to the lowest. They're at the mercy of a Medicaid system that is flawed, where there's such underpayment involved, and where people have been trained that they go to the emergency room for anything and everything. The physicians that work in those areas are basically also the same people that are compelled to do volume in order to survive. It's a situation that will not change until you start increasing the payment system to Medicaid.
Yeah, but what about
So hold on a second. So you see that too in the mortality rate, the maternal mortality rate, right? Medicaid covers 40% of deliveries in the U.S., and we have some of the worst numbers because of the lack of payment. But it's no longer the inner city. The rural kids, the kids in rural America don't have access to a pediatrician. They have the same fate as the ones in the inner city. And in many communities, this clinic that I help near Marine Base Quantico, 85% of the population is Medicaid. It's a suburb. It's not urban. But that's where the working poor go to live, and then they commute to serve the rich in Georgetown. So it's the same problem. So it's no longer a zip code problem. It's Medicaid is underfunded, broken, and a poor system to finance care for children. And it is preventing children in every community from having access to care. And quite honestly, what Aetna offers, a pediatric office, rates below Medicaid, I don't blame them, because I would say, Dr. Rogel, what percentage of your practice is Medicaid? Oh, X percent? But you seem to be able to make money off of them. So why should I give you a dime more?
The truth of the matter is, with the Medicaids, you don't have any co-payments or deductibles or co-insurance. It's the card. Come in, they bill, they're done. With Aetna or whatever, there's a co-payment that Mrs. Jones always gets mad about making that $25.
Yes. And when you look at what the Medicaid managed care companies, you're dealing again with a huge amount of the money going to administrative costs. That's absurd.
But you get my point, right? When you're willing to take $50 for a service that should cost $150, it doesn't matter what business you are. If I'm Walmart and I'm buying 1 million widgets from you at $50, and then comes Target and says, I know that these are being sold at Walmart for $50. So they're paying you about $50 for it. Why do you want $150 from me? I don't get it. What is it that you're doing for me that I should pay 3 times what you're paying Walmart? And so we'll never win. We'll never be paid appropriately as long as Medicaid exists.
Correct. Unless it's folded into a Medicare, Medicaid system as one system. And then you start dealing with a much larger group of physicians that are affected and are willing to put their necks out to try and change the system.
But even there, they passed this budget neutral law. And so every year we go through the same song and dance. We need to cut back physician payment by 3.5% to 4% this year in order to stay budget neutral.
A little less. It's 2.9%.
And then they dance and they he and they haw, and the AMA goes, the physicians won't take this. It's already hard to get a patient with Medicare. Medicare barely covers the cost of care. Our physicians are limiting the number of Medicare patients they see at Medicare rates, which is twice as much as what Virginia pays on the Medicaid side. And they go, okay, they figure a way, and they don't cut the reimbursement for this year. But next year they come back and we have the same dance.
Yeah.
And I don't know about you guys, but the people in this office that I help, they're nice people. They deserve a paycheck. They deserve to have a cost of living increase, because inflation has been 20% over the last 4 years. And they're having trouble buying eggs and chicken and steak at the supermarket for their families. Right. And we don't get paid any more than we did 4 years ago. But inflation is 20% higher.
It's actually worse. If you look at most people's contracts, they haven't changed other than minimal changes in how payments are divided. The overall payments by insurance companies have not changed significantly since the time you signed your contract. And that can be anywhere from 5 years to 15 or 20 years. And even CINs, which were supposed to be able to do negotiations collectively, have failed.
And so people talk about a higher minimum wage and living wages for people. All great. I think, yes, people should be able to have a job that pays enough so that they can feed their family and have a roof over their heads. How am I supposed to treat my employees when I am not giving more money to give them those raises that they deserve and they need to survive? What impact does that have on my family, on my community?
The impact is end up with inferior quality of employees as well.
Yes. And the ones that work for you struggle to make
It's okay, literally double reimbursement than an office.
They have leverage.
And again, it's a matter of how the pie gets divided. We get a smaller and smaller portion each year, and their portion goes up and up each year. Look at what the proposed Medicare changes are for 2025. Well, it's a budget neutral. If it goes down for physicians by 2.9%, it's going to go up over 3% for the hospitals.
Yeah.
Which is still it's not enough to cover the changes in medical costs to begin with. But even that what they're doing is just shifting the cost, and it's shifting payments from one pile to another.
Yeah. And the problem is that it's hard for people to understand. Healthcare is a local business. There's no part or very few parts of my business that I can outsource to China to a slave labor plant that makes 50 cents an hour. And so it is expensive inherently because of the amount of people you have to hire to provide the service. Whether you're a hospital or a physician's office, you need LPNs, medical assistants, receptionists, medical billers, and they need to make a living wage. And so there's no slack. But the people that do the work need higher wages because inflation's been 20% over the last 4 years. You have to pay more for the service. Right. But we live in an alternative reality of your healthcare. You're not a hospital, so we're going to cut your rates because we did it at Aetna, and we got into a Medicare Advantage program. We bought a couple of practices, and it's not turned out very well. We just fired our CEO. So who do we look for to give them a haircut that we can bully into taking our low rates? That's the shell game.
Right.
Okay. So I was going to ask you, you call on this for Medicare rates to be the floor. Why?
It's simply, why should one population be subject to lower rates than another population? It's the same kind of work, family practice, internal medicine.
This episode is sponsored by our friends over at Freed AI Medical Scribes. Let's hear what they have to say. What if you could take the computer out of the physician-patient relationship? With Freed, you can. Freed is the AI medical scribe that listens, transcribes, and crafts perfect soap notes for you seamlessly. This isn't just another productivity tool. Freed is a life-altering solution for physicians, helping you regain the joy of practicing medicine. Freed frees you from the burden of documentation, so you can focus on what really matters, your patients. With Freed, the computer is no longer a barrier. It's a quiet assistant that works in the background, capturing every word of your patient interactions, accurately and quickly. The result, you're fully present in each visit, building stronger connections and offering more attentive care. And when the day is done, your notes are too, leaving you with more time to focus on yourself, your family, and your life outside of medicine. Freed is the solution thousands of physicians swear by to reclaim their passion for medicine. Try it free for 7 days, no credit card needed. Visit getfreed.ai and rediscover what you love about being a doctor.
They're doing the same work, although actually less work in some ways, but because we get so much bundled together, why should we take less than our colleagues that are dealing with adults? It's actually ludicrous. We should be getting more than they do because we are taking on more responsibility and doing more work for each individual patient.
How about you pediatricians? All these stuffy noses, sore throats, and ear infections. They're not that complicated. They all get better despite what you do to them. That's what the insurance companies think.
Now, they know better. They want you to think that's their rationale for doing what they do. They know the answer. They know what's going on, and they understand how they can exploit the system, and nobody does anything to fight it. When I tried to fight it 25 years ago, not one person was willing to put their neck out to help me.
So let me give you a case study, which is very aggravating. North Carolina did not expand Medicaid. And there's a good reason for it. Many southern states have a balanced budget in the Constitution. You have to, and they have a rainy day trust fund. So you cannot take an obligation as a state where you don't know how much you're going to be paying. Now, finally, this year, they passed expanded Medicaid in North Carolina. The biggest not-for-profit health system in North Carolina's name is Novant. Novant Healthcare would not allow the bill to pass unless it was guaranteed that they would get from Medicaid patients in North Carolina the same as from commercial payers in North Carolina. But lo and behold, the internal medicine doctor, the family practice doctor, the pediatrician are not part of that deal. We don't even get 100% of Medicare. And we have the people from the AAP cheerleading. This is a glorious day. As a big victory for who? For the executives of Novant? It's not good for the state of North Carolina. It's not good for the children. It's not good for primary care. It's only good for the people that will reap the benefits, the big bonuses in the big offices of Novant. Talk about nonsense messaging. So the question really to me is, why are we cutting ourselves short? If Novant thinks that 200% and 300% of Medicare, it's what's necessary for them to provide care in their community, why are we not asking for the same?
That's why I said that should be a floor. Simply, it doesn't mean that this is even acceptable, but it should be an absolute minimum. And instead of 50, 60% of Medicare rates that currently are prevalent in most of the Medicaid managed care companies.
Yeah, I would just word it differently. I would be asking for 200 and 300%. Forget about the floor. because we might only get 120%. So we might as well ask for the moon and be happy when we get a bus ride down to DC. Your bill also suggests that we reform the way that vaccines are paid for so that we are paid at a percentage of the CDC price list on the private side. What are your thoughts? Why did you add that in there?
Vaccines are currently paid by whims of the insurance industry, of what they think they can get away with. It has nothing to do with even the CDC price. If they can pay less than what your cost is and get you and argue that, oh, we're paying you for administering the vaccine, we're giving you for an office visit, it should be just part of that whole thing, and we're giving you X dollars as a bundled package that's above what you would get if you just saw the patient and didn't give the vaccine, or sent the patient off to a city clinic or to a federally qualified clinic. That's fine. If you look at in any kind of industry, if you look at a plumbing supply company, if you look at an electrical supply company, there are formulas for calculating what it costs to keep idle inventory on hand. And that's the basis for that.
Well, when the vaccines are very inexpensive, like the IPV and the DHP, those are very small vaccines. You can keep them because they're going to go. But the Beyfortus, the new RSV vaccine, you know how expensive that is?
Yeah.
Well, hundreds and hundreds, $500.
If you look at your expenses, rent used to be the number one expenditure. Now it's probably vaccines that have exceeded that. So you're tying up so much revenue, so much of your practice expenses into vaccines. Why shouldn't you expect to be compensated for this, having the ability to store the vaccine for the patient that needs it? They are just whittling you down to whatever cost it is for the vaccine and not realizing how much time it takes for a nurse to draw up the vaccine, the alcohol, the Band-Aids, the whole thing. And they say, oh, that's a part of the administration cost. The administration costs don't cover those expenses, especially when you start factoring in the time it takes to interface with a registry and report this and provide the patient counseling and everything else. It just doesn't add up.
Correct. So I've heard from what I used to think was a good insurance company, now I think very poorly of them, that's okay. Physicians don't need to make money on vaccines. And it's not about making money, is what you said. There's a cost to that investment that I need to recoup. In Virginia, there is a Medicaid plan for people that are over the Medicaid threshold. And so it runs a little bit differently. So they're not eligible for VFC vaccines. And the state pays for those vaccines as if it was a private payer. And they pay below CDC cost in what you can buy the vaccines in the market, and they don't pay the admin fee. So you see the patient and then you send them to the health department to get the shot, because otherwise you're on a $300 vaccine. If they pay you $30 under and the physical is $70, you're way underwater now.
Yeah.
And what's interesting, I had the staff call the health department because this clinic honestly cannot afford to buy $5,000 worth of Beyfortus to have it sit in the refrigerator, so that if they get audited by BFC, they show that they have the same vaccines in the commercial refrigerator than they do in the Medicaid refrigerator. Yeah. So I called to see if we could send the high-risk kids over to the health department. And their answer is like, oh, we don't buy that kind of vaccine. That's too expensive. And so my question is, I don't know. I have tremendous respect for you and Dr. Kane and Dr. Birch. Why are we still short? Let everybody be on VFC. No, take that monkey off my back.
Vaccines should be a universal thing where you're paid according to again, that requires a legislative action. Vaccines shouldn't become a profit center. for a practice, and it shouldn't be a loss center either.
But why not everybody in VSC? What would be the regional objection to that?
There is no objection. The states would have to absorb the cost, and they won't.
Not necessarily. So Idaho's done it. Idaho's done it, and Rhode Island has done it. And what they have done is they put a tax on the health insurance premiums. And so that's how it gets funded. And so it's budget neutral for the state, but no longer is the health department or the physicians burdened with the tremendous cost of vaccinating society, because it's not our cost to bear.
No, it shouldn't be. It shouldn't be. Again, you're getting into an area where you're starting. Again, this is an area that the AMA would say is socialized medicine, which is inappropriate terminology. The same things were said when Medicare and Medicaid were first promoted back 50, 60 years ago. It's crazy. Vaccines should be something that is covered by the government and not a income generating center, but at least to cover the cost of administering it. And if you are going to be forced to store it, you still need to have that expense added into the administration expense. Of course,
because they come and audit you, they have to file reports, you have to have a backup generator, you have to measure the temperature in the refrigerator. It's not like they give it to you to hold in the refrigerator and you're like, we're done.
And then they penalize you if something goes wrong.
Yeah,
that's the other thing. And the VFC programs, at least in New Jersey, have been more punitive than educational. They do anything possible to make things more difficult for you, even if you have the most sophisticated refrigeration system and temperature logging. Disasters happen, power failures happen, and even with that, you're at their mercy. If something goes wrong, they hold you financially responsible.
That's right. That's right. And so I was in Rochester, I had a conversation with the CEO of a big practice, and he said his nurses were up in a tizzy because PFC came in, they audited them, and they were going like, you ought to do this, you got to do that. And he said, have the government employee come into my office. And he said, Medicaid's only 10% of my business. It doesn't pay very well. I do it because I think it's my obligation as a good steward to this community to do it. You can take all your vaccines today. Take them all. I won't see any more Medicaid patients. I hope you can find them a medical home. Is there anything else you need to discuss with me? No, we don't want you to. Well, we need pediatricians. Okay. So if you need pediatricians, you're paying me very poorly and you're going to make it a difficult day for me. I don't need you.
Have you ever tried to refer anyone to a federally qualified center or to a city clinic? They are so backlogged as well because of the same regulations that they deal with. And then they don't even accept certain types of vaccines. It's ludicrous. I worked for both at one time, and a long time ago, I worked for a city clinic health department giving vaccines. And when the meningococcal vaccine first came out, they would not stock it because it was just too much of an expenditure and risk involved. The same thing has happened with the HPV vaccine. They wouldn't stock it for the same reasons. Then when it comes to federally qualified center, and the rules are varying from state to state. There needs to be some federal uniform policy. In New Jersey, if you are uninsured, you can't give the vaccine to a patient. It's just crazy. If you are underinsured, you still can't give it to a patient. You have to send them to a federally qualified healthcare center.
Yeah, part of the terrible poor rollout of before this was that only 10% of maternity wards in the U.S. participate with BFC because the hepatitis B vaccine costs like $15 a shot. And they're like, there's no way we're going to fill out all that paperwork, even 50% of our deliveries are Medicaid, to get a $15 freebie. Forget it. We'll lose the $15. It'll be so much easier. So none of the hospitals, 90% of the hospitals will not give Beyfortus in the nursery simply because they don't want to deal with the bureaucracy.
Before this, not $15, Herb.
No, but I'm telling you, the hepatitis B is cheap, so they lose that $15.
Yes.
Just they can't feel that.
But even regardless of that, the other issue is most of the hospitals that even do give the vaccines are not reporting it to any registry.
Yes, they're not.
Whereas if I were not to report something to the registry, I would lose access to the FC.
And so there's a great administrative burden, particularly to primary care physicians. What do you call to change that administrative burden?
There needs to be a federal policy on the FC. It's a federal program. It should be uniform from state to state. Number one, it should be something that is livable and enough to cover the overhead cost of doing it at a bare minimum. When it is being that it's being used for patients that are of questionable income or marginal incomes, it's not a matter of making money off of the government or off of the patients. It's a matter of at least covering your expense and overhead. And if they can't do that, the system is going to fail. And when the system fails, you have kids that are going to come down with pertussis. You have kids that are going to come that 30, 40 years from now are going to come down with cervical cancer. The RSV patients, the kids that are going to end up in the PICUs. If you look at the cost that then end up going to the government for uninsured patients in the hospital, it's absurd. Why they wouldn't do something to cover those minimal costs.
But look at it, vaccines as you need shots to go to school. It's nothing else more than that.
Yeah.
And the importance of vaccines.
That's a failure of the AAP communication. They purport to represent us. Why are we not heavily invested in media campaigns that show the value of each vaccine so people know that it's not just a shot? It's something that's going to keep you from having cancer. It's something that's going to keep you from being an iron lung, and that taking care of a kid with pertussis in the PICU costs $50,000. $50,000. That's what the average PICU admission costs.
More than that.
But you can't blame the politicians. You cannot blame Joe Citizen because
they don't know.
No one tells a story.
That's what I said from the beginning. The first thing that we need to do is a publicity campaign and an educational campaign, and it has never been done. But people don't understand. When I first started filing suits against the insurance industry, it all came down to one particular case, and it had to do with a kid who had massive tonsils covered in pus on a late evening. I did have a Coulter machine so I could run a CBC on it. And the insurance company that was involved would not cover the cost on regular visits. I called them and I said, this kid, first of all, I called them because I was going to have to refer him to the emergency room. I said, he's either got a peritonsillar abscess or he has mono. If he has mono, I can give him a injection of some steroids, send him home and see him tomorrow. And if it's an abscess, he's got to go in for the hospital and needs immediate surgery. The difference is $10,000 to you. Will you cover a CBC that I do in my office for $30? And they said, oh, yes, we'll do it. Then they never paid me. And they denied all my appeals. That was the start of when I started to look at what was going on with payments. But it all came down to simply a matter of there's certain types of expenses that the insurance company is so short-sighted on and doesn't understand how much they are losing on the short, how much they're saving on the short term and how much they're losing in the long term. And the same thing with vaccines.
You're probably young enough to remember when Rocephin first came out.
Oh, I do.
And it was so expensive that you saw a child in the office that needed Rocephin to keep him out of the hospital, and then you have to send him to the ER so that you could get the Rocephin in the ER and go home and see you the next day, because you couldn't afford it in the office. And that's another example of penny wise, pound foolish. But there are more burdens in that in administration, right? Billing is a tremendous burden on physicians. The EHR and the reporting of these quality metrics, many of which do not improve care or outcomes or population-wide outcomes. The maintenance of certification from the American
That's a joke.
Pediatrics, which is a total joke. It's a rent-seeking organization whose CEO makes over $1 million taxing pediatricians to maintain their certification.
I dropped mine.
And that also needs to be addressed. All of these administrative burdens that do not make our population better, do not make our quality better, does not make me better as a physician. What are they doing there other than making a few people very rich?
I dropped my board. I shouldn't say board, Academy, American board certification, ADP board certification, probably about 7 or 8 years ago after going. When I first finished my residency, there was a time lapse where you had to complete a certain amount of years before you were even eligible to sit for the boards. I had to wait 2 years to take my written exams, and then I applied to take my orals, and because of where they were being given, I elected to postpone it for a year. And shortly thereafter, they changed their policy. And when I did take my boards, it was already past the point where I would have been grandfathered. So every 7 years, I had to go through the whole rat race of spending another $1,000 plus doing maintenance of certification and all that and maintain my boards. And after going through it 3 times, I said, no more. That's it. I'm not going to keep subsidizing an organization that is only interested in money making.
Well, it has a cool plural, a dashboard with lots of technology. Has to be paid somewhere.
Yeah. Feed the beast.
Yeah, it's all about a board that makes a lot of money off the backs of hardworking clinicians. That is disgusting.
Provision.
What I say we're at an inflection point. I think people that are much smarter than me, Dr. Hackle, say that we are at a crisis moment in pediatrics. What needs to be done to build out workforce capacity and attract young, talented people into the specialty so that children in every community from every walk of life have access to care in the U.S.?
Has to do with making it attractive as a specialty, not just because, first of all, there are a certain number of people who are going to go into it no matter what because of just the desire to do good and be a good person, and they like the challenge of being a little bit of everything. The gastroenterologist, the neurologist, the simple surgical stuff, the just having the relationship with a family. Those are all key factors why people go into pediatrics. Then there is the financial issue. And as long as it's not something that is at the top of necessarily of the payment scale, but it's definitely in the middle of the scale, it will attract people. And we're far from that.
Yeah, and you alluded to this before. I don't regret having become a pediatrician or a physician.
Neither do I, for the record.
But there's a tremendous price that we all paid for this privilege. We gave up our 18 to 30-year-old selves in the pursuit of this career. no amount of money will replace a young Herb. I cannot relive that life. And that sacrifice needs to be compensated with a stable job that's competitive, that allows me to live in the community that I want to live in, an upper middle class existence. Because if you're going to pay me less than the salesperson for Oracle across the street from my house, who partied through college and started working when she was 22. And I'm not even talking about the investment banker in Manhattan, or the lawyers that are now demanding between $1,000 to $2,500 an hour at the big law firms. Why should I sacrifice my youth to make a little more than what the UPS driver makes? Why? Because I'm stupid?
When the police cities make more than we do, it's absurd. When education is not valued by the system, you have a failed system.
Right. So I think I think your proposal, your paper doesn't go far enough.
No, it doesn't.
I think that we need to start putting our big boys' pants and skirts on and saying it is unacceptable for a pediatrician to make less than $350,000 a year if they're working full time. That is what the average U.S. physician makes. Now, you can say physicians shouldn't make that much money, and I'll say Taylor Swift shouldn't make $1 billion a year selling records. But she does. And if you want to attract the top, most talented people to take care of the most important asset that a society has in every community, whatever color of their skin there is, whatever the income is, it is our children. And we need to pay them so that we attract them and keep them on the workforce. It is not acceptable to pay them less than a police officer or a fireman, firefighter, or firewoman, and then forget about our children. This is not acceptable.
There is a shortage of pediatricians already. I have medical students, and I have never met one that said, "Hey, I want to be like you, doc." And the school is discouraging them from going into pediatrics. They're literally telling them, "Don't go because you'll make no money."
This become the field for nurse practitioners or PAs these days.
They don't want to. They don't want to.
They don't want to.
That's
They
enough.
Nurse
No.
practitioners want to work with the doctor and give Botox.
Less than a third of nurse practitioners want to go into primary care because they can go work in a dermatology office and make $150,000 a year, or they can go work in a pediatric office and make $90,000 a year and hustle. And they're like, why? Why would I give up $70,000 in income and have to take care of a pager on the weekends? No.
And not only that, though, the whole issue is even that the whole aspect of, I would call them paraprofessionals, has overrun medicine to an extent that is totally unacceptable. And until you end up with more cases where there are disasters hitting the media, no one is going to give a damn.
Sorry, I interrupted you.
I was just going to say that years ago, if you remember this design case, Mount Sinai, which had to do with overworked residents, it was only because the child that was involved was the daughter of a very prominent person in the city of New York that anything changed.
Or the Bell Commission.
Yeah. Yes.
Bell Commission.
And then the same thing happened, I think, at Hopkins. There was some disaster.
Yeah.
And the family had a lot of money and they forced change. But I have a very simple proposal. I think it's very fair. Anytime that a nurse practitioner or a PA presents themselves to a patient, they need to explain that they are a nurse practitioner and that their training involved 18 months of a master's program. because what they have been playing on is confusing the consumer that because they wear a white coat, that they have the same training as a resident trained physician, and they don't.
Well, that's because of
Now,
what they've done in the media.
now you can choose to take care from a nurse practitioner. If I have a sore throat and I need a strep test and I don't want to drive all the way to the office and swab myself, the nurse practitioner, the minute clinic will do the job for $50. What do I care? Sure. So there is a role for them, and some of them are very talented and very smart. And when they work in a team, they're incredibly helpful. But let's be honest to the consumer what you're getting, because you're paying the same for that nurse practitioner's time as you are for a board certified pediatrician.
Correct.
Yes, it's the same thing if you go to, and then you mentioned about lawyers. If you go to a big law firm, after your initial consult with them, most of the time they will tell you, I'm going to have a paralegal help you and take care of this matter. It's only a couple $100 an hour as opposed to my fee. But even at that, you're talking about 10 times what we are seeing in revenue and medicine.
Yeah. And a paralegal will never be allowed to argue a case in the court.
They'll tell you right up front that I'm a paralegal and that I am working under and that everything we do will get reviewed by your attorney.
But you cannot be a paralegal and walk into a courthouse in the U.S. and represent a client. No, it is not allowed, because the lawyers are not stupid. They're not going to let somebody eat their lunch.
Medical economist from Princeton, who used to write a series of articles in the Wall Street Journal. There ain't no free lunch.
No, there's not. There's not. Every value is a relative term, right? Value is a combination of service, quality, and perception. So some people pay $1,000 to stay at a Ritz-Carlton. They could probably get, I don't know, at a Holiday Inn, a $200 bed that's clean and you can sleep in. But that person, for whatever reason, likes the perceived value of paying $1,000 and telling their friends they were just in Miami for a week at the Ritz-Carlton.
It's like the difference between buying a Subaru or a Kia versus buying a Mercedes.
It's the same perceived value. But there's a component to quality that is inherent to value. When in the old days, the German engineer cars were far ahead than anybody else. Their engineer was very solid. I still drive a Mercedes that's 25 years old. So it costs a lot up front. You can't kill it. That was not true of the U.S. auto industry in the 70s. It wouldn't last 2 years.
That's why I started buying Japanese cars.
But then Toyota came around, right? And then the cars last 30 years and they don't cost as much as the Mercedes. And then eventually all the nice safety features of the Mercedes were added to every other car. The value proposition changed.
Yes.
What do you think needs to be done next? What is your next step?
And to try and drum up enough support for this to be able to present it to, actually, I tried presenting it to a couple of media outlets for this hope that getting it published so that it would attract more attention. And each time it gets denied. I tried to publish it in JAMA. They turned it down. I sent it to the New York Times. I sent it to the Washington Post. They've all denied it, or not denied it, declined it. I still hope that there are ways of getting this out to more people to generate more understanding of what's going on and perhaps find a way to get it into some congressman or senator's hands that will understand the value of what is being presented and push for some legislative change.
Hopefully, David Cloud will get some noise out there, some commotion.
I don't know if you saw that article published in Time magazine
Yes.
about how the lack of payment and how little Medicaid reimburses is denying access to children all over the U.S.
Well, denial of access. The other issue is you could go through the judicial route, but I'm not going to be around to 25 years to see it through. And I haven't had been enough class action cases to know that even if I were to file one on denial of access over some of these points, it would take another 20 years. And on top of which, most of the insurance companies have modified their contracts to create clauses in there that prohibit litigation, which again would require another Supreme Court decision to determine whether you can actually sign away your rights to suit in advance without any foresight. So there are a whole bunch of legal issues that would need to be addressed that are better addressed in Congress than in the courts.
Okay.
Do you think that the U.S.-based pediatrician has a spine?
You know,
No.
should that even finish in your sentence? I don't know.
Right. So we like to complain, but when it comes to the moment where I say, all right, let's get 300. I don't need 3,000. 300 pediatricians to write $1,000 check, and I'll hire a lobbying firm to lobby in DC on payment. That's it. I don't care about gun safety, pool safety, how butterflies fly, how butterflies don't fly. There's 1,000 good causes, but I need pediatrics to survive. I need children to have a good pediatrician in every community, irregardless of their color or their skin or their ability to pay. You think I could find a 300 that would donate $1,000? No. You do?
No, I don't. I don't think you'd try. If there was $100, I don't think you would find enough because otherwise it would have been done. I have tried in the past to create other things and do a certain amount of advertising and solicitation, and it would have required a fraction of that for legal expenses, and it always ended up, oh, yes, this is wonderful. When it came time to write the checks, everyone backed down. Part of it is that they don't have the money, but which is partially true. The part of it is that they just don't understand the need to do it, and they're worried about today, not about tomorrow.
That's regrettable. And I think that what I think is maybe you can't do 1,000, maybe you can do 500, maybe you can do 250. Or maybe you can contribute something, and those dues to the AAP are very expensive. And our voices are not being represented, and the specialty is dying. So
Got to GoFundMe, Herb.
we should be very adamant about holding leadership at the academy that this is an important issue, because without pediatricians, moms, and school teachers, children in our communities do not thrive.
Mm-hmm.
And if you're an advocacy organization for the betterment of children, you must take care of the pediatricians first. Just like in the exam room, we take care of the families, because without a mama and a dada, I cannot take care of that child. I see him for 10 minutes. They go back home and the parents care for them. So I think we still have a ton of work to do.
Oh, absolutely.
But I very much
This is
appreciate
the beginning.
I very much appreciate the time you spent thinking about this and writing this with Dr. Kane and Dr. Birch and Dr. Sawatsky, phenomenal colleagues, very well-meaning and intelligent and very thoughtful. I wish you the best of luck, and let's see how we can make this a reality.
Yeah, I'm planning on expanding each of those points into a separate essay and trying to generate more interest.
Okay.
Great. Thank you for being on the show. Thank you for your